All right. So thank you for having me here tonight. I love talking about Lyme and co-infections. I do it all day in practice, and I do it in my free time as well, apparently, as evidenced by tonight. I was thinking about it the other day, and I think it was about 3 years ago I spoke to this group about LDI, actually, and I'd been only using it for about a year at that time, and I'm still using it now and still love it. So that's stood the test of time. It's like, wow, I can't believe it's been 3 years since I spoke to this group. In terms of testing options and persistent Borreliosis and co-infections, I don't know if anybody noticed that I actually just put up the title here because this was I stole some slides from another presentation. So anyways, this is the title I came up with about 2 minutes ago. But I think this is a really important topic, fully evidenced by the discussion that was happening here, talking about testing options and whatnot, and saying things like the testing is not good, or maybe some stronger language was used by somebody in the room. And about 2 years ago, if somebody pulled me aside and said, what do you really think about the testing options for Lyme? I would have said, I was telling a lot of my patients, I should say, it's fine to get tested, but there are a lot of limitations. It's quite, it's not all that versatile, reliable, reproducible, all that type of thing. In the last couple of years, though, I started using some other labs, and I'm going to talk about them today. And my story has completely changed. Yes, there are limitations to the test I'm going to talk about today. Nothing's perfect, but there's quite a bit more versatility. So we'll talk about why I'm saying that and why I do recommend them. And nowadays, when I go to conferences, I was just at one in Chicago a couple of months ago, and everybody in the room was Lyme literate, medical doctors, doctors of osteopathy, naturopathic doctors, some acupuncturists, like just a nice mishmash of different practitioners. And there was definitely some people who were like, yeah, like why test? Like, talking at lunch or talking at on breaks or whatnot. And it seems like there is still quite a bit of misconception out there, if you will, about the different testing options that are actually available. So we'll talk about them today, and you can be the judge, see what you think. So just in terms of disclosure, so I have no financial interest in any testing method or any other option or any other topic rather that I'm going to talk about today. And so specifically by that, I mean that I'm not on the staff of any lab. If you do testing, whether it's mediated through our clinic or not, we don't make any money from that at all. You pay the lab directly, and there's no kickbacks or anything like that. Yes, if you come in to have your blood drawn at our clinic, then we charge a blood draw fee because my residents don't work for free, unfortunately, so I have to pay them. So we have to charge you for their time. But over and above that, there's no financial interest at all. So anything I'm recommending is strictly based on clinical validity, in my opinion, and experience and practice. So I think like 50% of you know who I am, and then I think I've met a little over 50% because I met at least a couple of you at the vocal event. But just a quick note about who I am. So I have a practice in, I should say, Bedford, Nova Scotia. This was from a talk I gave at that conference in Chicago. So I just said Halifax because who the heck has heard of Bedford, Nova Scotia if you're talking to people in Chicago. At my practice, I have, as I mentioned, a couple of residents. They're naturopathic doctors as well, and they're basically my arms and legs, and I couldn't function without them. And then there's another ND that I've been practicing with for several years now. So there's 4 of us out there practicing in Bedford. We're out in the Bedford Commons, so right by the Tim Hortons, or in the big Walmart, big box store area, which is what everybody knows. And then they're like, oh yeah, there's a naturopathic clinic over there now. I obviously specialize in chronic infections, or else I wouldn't be here talking to you today. I also specialize in pain, which of course a lot of chronic infection patients can have pain, but I also treat patients that have sports injuries, post-motor vehicle accident injuries, arthritis, that type of thing as well. Do a lot of integrative cancer therapy, which is usually not so much related to Lyme or co-infections, autism spectrum disorder, ASD, which can be related to Lyme or co-infections sometimes, neurological disorders, oftentimes related to Lyme and co-infections, it seems, and then basically anything chronic/treatment resistant. So our clinic has gained a bit of a reputation over the last several years where we're kind of known as the clinic that treats the cases that have a hard time getting better. So we get a lot of referrals from other NDs and other healthcare practitioners and some medical doctors and all of that as well, which is really great. And it's why I have gray hair, because I just treat hard cases. But what can you do? And my children as well. I can blame them for that as well. We use a lot of different therapies at our clinic. If you go onto our website and look at my biography, beneath my little write-up about myself, there is a list of all the courses that I've done over the course of time. It hasn't been updated in a couple of years because I've been too busy. However, as you can see, if you look at that list, you'll see I'm completely addicted to continuing education. You looked at it? Yeah, it is. Yeah, it's actually longer. I didn't put everything in there, but oh no. Okay. Oh, good. I'm glad. I'm glad it was a good thing. It's not like, oh, this guy's obsessed with naturopathic medicine, etc. So that would, hopefully that's a good thing in this context at least. The long story short is that treating chronic/treatment-resistant patients requires learning a lot of different things because there's definitely no one-size-fits-all protocol for everybody. And I've got to have lots of tricks in the tool bag because every case is certainly nuanced, to say the least. So part of our tool bag would include doing IV therapy. So we do intravenous laser therapy, ozone therapy, IV nutrients, chelation therapy for heavy metals, a bunch of other things. Basically anything that's not pharmaceutical, because we're not allowed to prescribe pharmaceuticals in Nova Scotia, hence the lamenting. There's only like nobody in Nova Scotia and 3 doctors in Canada or whatnot that will prescribe for these types of conditions. But anything that's non-pharmaceutical, we basically do it. So if you're like, oh, do you do IV NAD? It's like, yes, we do, and so on and so forth. Phosphatidylcholine, things like that, glutathione, etc. We do a lot of injection therapies, which some, like ozone, can certainly be very pivotal for some cases of Lyme. The other ones are mostly for other types of pain and whatnot. And then we do use other select therapies like herbal medicine, something called endobiogenic medicine, and anyways, the other things that are listed there. So why bother testing for Borrelia and co-infections? So we'll talk about that on the next slide, and then different types of testing that are available. So antibody-based testing, which when people talk about testing for Lyme and co-infections, they're usually talking about antibody-based testing, the ELISA and the Western blot test. We're also going to talk about Tcell-based testing and DNA-based testing, so which are types that are the things that got me more excited and had a renewed hope and interest in testing after, as of a couple of years ago. So why should we bother testing for Borrelia and co-infections? So a couple of reasons. The main one for me is it's good to know, are we actually dealing with a chronic infection or not? The problem with Lyme, of course, is that it's a great mimicker, and unfortunately, a lot of other conditions can mimic Lyme. So a patient walks in saying, I've been tired for 15, 20, 25 years or 3 years or whatever it happens to be. I have headaches. I've got funky neurological stuff going on. And I have pain, let's say. Well, yeah, that could be Lyme, could be Bartonella, could be Babesia, could be Ehrlichia, like name a co-infection. Could also be heavy metal accumulation. If there's digestive issues too, could be a yeast overgrowth in their gut, could be something called small intestine bacterial overgrowth, or SIBO for short. I've treated about 1,000 cases of SIBO to date because we do in-house testing, so we have these stats easily accessible as we see how many tests have we run, and it's been 1,000 for my patients anyways, and tests for some other doctors as well. And the vast majority of those cases have fatigue, funky neurological symptoms, headaches, that type of thing. Granted, I can pick a SIBO patient out of a lineup and a Lyme patient out of a lineup pretty well now with clinical experience, but sometimes they can mimic each other or mask, a certain condition can present as if it's something like Lyme, if you will. Something called methylation cycle issues, detox pathway issues, the other things listed here, they could all present with those classic Lyme symptoms. Granted, a patient walks in saying, I have these weird internal body vibrations. It's like, well, that's pretty hard to find another condition that's not chronic borreliosis, persistent borreliosis, chronic Lyme disease, whatever you want to call it, that doesn't cause that. So that's a pretty dead giveaway, but not every Lyme patient has that. Patient says, I've got, burning pains in my feet and my lymph nodes are swelling up like golf balls. Like, well, that's probably Bartonellosis, but so it's pretty much a dead giveaway, but it might not be, or maybe there's Bartonella and that's 25% of what's causing their debilitating fatigue and pain. The other 75% is due to something on this list or something else. So it's really useful, in my opinion, to run tests because then we know what we're actually dealing with. I've had quite a few patients to date come in saying, nobody can figure out what's wrong with me. I went to a meeting like this one, and not necessarily this meeting, but there are others around the province as well, as I'm sure you know. And everyone said, get tested for Lyme because nobody can figure out what's wrong with you. They don't know why you're chronically fatigued or whatnot. So get tested for Lyme. And I've had a number of those patients come in, and after talking to them, I say, I think you've got something else going on. And sometimes we'll test for Lyme anyways, because I'm a people pleaser. I'm happy to test whatever they want. It's their money. They can test for it if they want. And there have been many cases where they come back just flat out negative across the board for Lyme, even with some of the better tests or the quote unquote good tests that I'm going to talk about today. And we test them for other things and see there's actually something else going on. So it is very reassuring to me now to have tests that are, in my opinion, much more reliable than standard antibody testing, because then we can see, well, what's actually going on? Or I've had other patients where I'm treating them for Lyme because clinically it made sense, or co-infection Lyme. When I say Lyme, it means Lyme or co-infections, kind of a catch-all term, I'm sure in this room as well. And we'll be treating them for Lyme, and they'll say get 25% better, and then they kind of hit a plateau. And we talk and see, well, maybe you've got something else going on, and lo and behold, we test and we see there's something else going on. So it's not always Lyme, or it's not always just Lyme, so the testing is quite useful. If you've been treated for a period of time, you say, I improved and I plateaued, well, maybe retesting with one of these more useful tests that I'm going to mention could be really useful to see, well, maybe you got the Lyme, and maybe there's something else going on now. Like, in other words, maybe you cleared the Lyme or killed it off, and there's something else going on. So I think it's really important to test, and it's nice we have some better options. Any questions about that?
Perfect. Sorry, you mentioned vibrations?
Yes.
I don't know. Can you explain what that means?
Sure, yeah. So I mentioned vibration. So there's this symptom where patients will come in. Well, so it could be the gentleman in the back pretending like he's tremoring, like someone with Parkinson's.
That's what it feels like, but my hands aren't moving.
Okay, there you go. Yeah. So what I hear most often is sometimes people say, it's my whole body doing that. You're saying just your hands do that. Okay.
Just my hands.
Okay. And then I've had other patients say, it just feels like the core of my body, like I've got this like pole going through me, if you will, or this core inside of me that just feels like it's vibrating all the time. And people look at me and I'm not vibrating or tremoring in any way, shape, or form, but I feel that. So that's a fairly textbook symptom associated with Borrelios specifically. So that's what I meant by internal body vibration, so to speak. So other reasons to test for Lyme and co-infection. So it's good to know for everyone's peace of mind. So, some patients will come in, and like I've treated a wide spectrum of people over the course of time. And some people come in saying like, I'm so happy I just found someone who will treat me. I know I've got this. And I say, I am very confident as well. Let's just treat and go from there. I have other patients who come in saying, I've been sick for so long and I think I might have this. And I say, yeah, you've got all the textbook symptoms. Let's just start treating you. Let's save you several $100s and not test. And then they'll say, well, I just really need to know what's going on with me. I've had patients where after they're even getting better, they say, I still want to run that test because I just need to know. I need a piece of paper saying I've actually got X, Y, or Z. So for peace of mind, and and I like to know too, if the testing, as I've said many times in practice, if the testing was $20, I'd say let's just run it on everybody just for fun. But it's not. It's markedly more than $20. But it is good to know for everyone's peace of mind that we're actually dealing with the right thing, or the thing that we think we're dealing with. Another reason that it's good to test for Lyme or co-infections is to know, is it a past or a current infection? And if it's a current infection, is it a major issue or not? So as we'll discuss, one of the limitations of antibody-based testing is that it doesn't necessarily indicate that there's actually a current infection. It tells you you've been exposed, but doesn't necessarily mean you have an active infection. And that's a big limitation, because if someone gets tested, say they had a Western blot and it said they're, yes, they have Lyme, and then they're treated and they get 50% better, say they're using antibiotics, they're using non-pharmaceuticals, or they're using both, they're using whatever, but after a period of time they hit a plateau and they just can't get over it. Well, if you retest with a Western blot, what's the point? Because if it comes back negative, you think, well, it's got depending on who you talk to, a 50 to 75% sensitivity. So if it comes back negative, maybe the test just didn't pick it up. Or maybe if it comes back positive, it doesn't mean that the patient suddenly has more Lyme in them. It might be still reflective of the fact that, yeah, you were just exposed to it and you have a long-standing immunity or an immune system response to it. So some of the other tests that we're going to talk about today ultimately indicate or strongly seem to indicate whether there's actually an active infection, and then furthermore, how problematic is it? Because testing positive, say for Borrelia, Bartonella, Babesia, and Anaplasma, well, that's all well and good, but maybe only one or two of those bugs are causing the major issue. And if you're going after all of them with two barrels blazing, well, that's a cumbersome protocol, it's an expensive protocol, all that type of thing, and maybe we want to put our eggs in the baskets of the attacking those microbes that are actually the most problematic. So we'll talk about this quantification test coming up soon. The final reason here, and I'm sure there's many other reasons too, but the final reason I came up with for this talk is that different microbes induce different pathophysiological mechanisms. So you need different treatment depending on what microbe is afoot, and we'll go over an example of that. So I'm a huge fan of Stephen Buhner. His books are amazing. They're basically like the Bible of Lyme and co-infection physiology and pathophysiology, and in terms of herbal treatment, at least, it's just nothing is better. He's an incredibly meticulous researcher. Research compiler. He's an herbalist, and I don't believe he has a lab or anything like that, but he is very good at compiling research. And basically in his books, this is taken from his Bartonella co-infection book, so just one example of, why is it good to know which bug are we dealing with? And one reason is that, say, with Bartonella, it promotes the production of this cytokine, which is a cell signaling molecule in the immune system called interleukin 8. And then interleukin 8 basically causes these CD34 positive cells, these white blood cells, essentially, that Bartonella likes to hide inside of. So when there's more interleukin 8, it brings more of those hiding places or houses, if you will, for Bartonella to the site of infection, so they have more places to live. And then it also ultimately leads to more neutrophil production and these MMPs 2 and 9s to allow for more tissue proliferation. So in other words, interleukin 8 makes it easier for Bartonella to live and thrive and penetrate deeper into the tissues of the body. So we'd want to work with things that help to inhibit that, such as these herbs, which I won't bore you with the names of, but then also certain antibiotics. So doxycycline and minocycline both inhibit those as well. These EGCG, which is green tea extract, and acetylcysteine, which is this nutraceutical supplement, these have all been shown to inhibit interleukin 8. So if I know that my patient's dealing with Bartonellosis, then I'm going to want to pay attention to trying to inhibit interleukin 8. On the other hand, if my patient has, say, neuroborreliosis, so Borrelia/Lyme in the brain, well, neuroborreliosis promotes this expression of something called indolamine 2,3-dioxygenase, or IDO for short. IDO is this enzyme that basically causes tryptophan to break down. Tryptophan is this amino acid. It's the building block of serotonin. Serotonin is a building block of melatonin. So serotonin to make you feel happy and motivated and all of that, helps you to sleep. Melatonin helps you to sleep. Strongest antioxidant or one of the strongest antioxidants in the central nervous system. So really important for brain health and protection from things like chronic infections like Lyme or others. And basically you don't want your tryptophan to be broken down willy-nilly by something like Lyme in your brain. When tryptophan is broken down, I'm once again not going to bore you with the names here and all of that, but basically it leads to the production of something called quinolinic acid and kynurenic acid. And quinolinic acid promotes neurodegeneration. Your body's supposed to create kynurenic acid at the same time, but when your neurons are damaged by something like Lyme, you can't make as much kynurenic acid, so you get all the degenerative stuff and you don't get the healing protective stuff. So you wind up with this sort of vicious cycle of brain breakdown, which some patients can unfortunately really identify with that description of their brains. So the treatment for that particular pathway to inhibit IDO and also to help protect the nervous system are different herbs, melatonin, selenium, etc. So it's really good to know what we're dealing with, because it allows for a more fine-tuned treatment protocol. It also gives us a better insight into explaining certain symptoms, because we know certain symptoms can be associated with certain infections, of course. So several reasons why one might want to test. Any questions about that? Right. Just playing for time. I just need a drink.
Question.
Sure.
Maybe you're going to touch on.
Oh, please.
As a naturopathic doctor, aside from the tests, I've heard a lot about brain scans. Is that something that you're going to speak to about, Lauren?
So asking about brain scans, and do you mean something like an MRI?
An MRI. Is that something that you ever recommend they should do, or?
So do I recommend MRIs for patients? A lot of patients that I've seen where they've been through the healthcare system quite thoroughly for the most part have typically had an MRI, and it either comes back showing everything's fine, or they'll show some white matter lesions, which will be like, oh, maybe I have MS, and then they do further testing, they go, oh, no, I don't have MS, and then sometimes they do have MS, and sometimes those patients have Lyme, and we treat them, and their MS gets better, goes away, which is pretty exciting. So I don't recommend it because it's a really non-specific test. And I mean, I can't refer for, like as a naturopathic doctor, I can't refer for one, but I'm not sitting there with patients saying, yeah, you should really try to get your MD to refer for one, because it's just so non-specific. And I heard somebody say before we started something about, oh, those are just old age spots. And were they talking about a brain? Yeah. So yeah, I know, it's like, really? Like, I don't know. I don't want.
We're talking about my brain, but
Uh-huh.
I'm talking, I think, lack one.
I see. Yeah, sometimes if there's only one brain and two humans there, it's interesting.
The nicest way.
Fair enough. So yeah, you're welcome. Yeah, it's a good question.
Because I haven't had my brain scanned, and I'm wondering
Uh-huh.
if I come see you if you're going to tell me to go see my doctor.
Right.
Done.
Yeah.
Okay, thank you.
Yeah, sure. Yeah, no problem. It's a good question. So we'll talk about antibody-based testing first, because that's the one that everybody knows about, and I'd like to talk about that. And I think that, well, okay, I'll go through it. The slides in order here. I'll eventually get to what I was just about to say. So basically, with antibody-based testing, so just very rudimentary crash course in human immunology. So basically, a microbe enters the body. These specialized cells basically present the microbe or its body parts to the immune system, saying, "Hey, immune system, here's this thing. What do you think?" And the immune system will say, "Hey, that's not supposed to be here." So various immune system cells are produced. One type of which are antibodies, also known as immunoglobulins, or IG for short. And so effectively, IgM antibodies are the first type of antibody that's produced. IgG antibodies are produced afterwards, so it's kind of more of an acute phase marker versus chronic phase marker. And so that's why when we look at Western blot tests, then they're looking at these IgM and IgG antibodies. The ELISA test is also an antibody-based test. It's done differently than a Western blot, but basically it's looking for antibodies to a specific part of the Borrelia itself, but it's ultimately still antibody-based testing. So one question that I think is important to ask, and the 2017 vocal event, I talked about the different studies out there, and I really delved into it for that presentation. It was really interesting because you hear a lot of things at conferences and from colleagues and whatnot, and then actually looking at the research, I think is really important, because in my opinion, it's always good to make decisions and opinions and whatnot based on evidence. It's an interesting metaphor for what's happening in the political sphere and all of that as well, where we're fact-based things, what a novel concept. But the long story short is that if you asking the question, why are medical doctors, including infectious disease doctors in Canada and the States, why are they so hung up on the ELISA test? Why are you told that if you have a negative ELISA test, you definitely don't have Lyme? Is it because there are is there some malicious component or something like that? It's I don't think so. I think it's that they're looking at studies that ultimately say that that's what's happening. But then if you look at all the studies, you see, oh, there's actually more to the picture. And so I think I can't speak for them because I'm not them, but basically, if you look at the entire picture of all the studies that have been done, which I'll show you a little snapshot today, it's oh wow, there's clearly something more going on here. But if you just look at the study saying the ELISA test is perfect, and then you don't look beyond that, then I guess you're left with that opinion, because if that's all you're looking at, then that's what you're going to base your opinion on, I suppose. So studies looking at the standard ELISA testing in acute stage Lyme show it has a half decent sensitivity in the first 4 weeks, not great, 60%. Sensitivity refers to how good is a test at actually picking up the presence of an infection. So if there's a room full of 100 people, they all definitely have Lyme. They contracted it 4 weeks ago. There's a 60% chance, or 60 of them, I should say, will test positive with the ELISA test. After 4 weeks, 95% of those individuals should test positive. So 95 of that 100 people would test positive, which those numbers sound amazing. And there's a link, if you're interested, to this website that is a pretty good summary of the different studies that are looking at the ELISA test. And so, as it says here, that seems to have led to this general belief that a negative ELISA test is a great way to prove someone doesn't have persistent Borreliosis / chronic Lyme disease. Because if you look at that and say, well, geez, after 4 weeks, so if you say, Doc, I've been sick for 20 years, and can you test me to see if I have Lyme? It's oh, I've got the perfect test for you. It's an ELISA test. There's a 95% chance, sensitivity to pick up whether you have Lyme or not. And so when patients come in saying, yeah, like I was tested twice or 3 times, like I believe that what's happening there is the medical doctor's thinking, okay, there's a 95% chance that the fact that it said it was negative means you don't have Lyme. Let's test it one more time because there's that 5%. So now, statistically, and it's been a little while since university statistics, but, 2 95% sensitive tests is probably about, say, 97% sensitivity. The patient comes back saying, I know I have Lyme, please test me again. They're like, okay, there's a 3% chance that this is, 2 are wrong, so let's do another one. And it just gets to the point where they're thinking, this is 95% sensitive. How could it be wrong this many times in a row? And so when you're aware of the fact that that's the information that they have been given, it's like, wow, well, maybe it makes sense that they're saying, yeah, let's put all the eggs in the ELISA basket. So I just think it's an important thing to know where people are coming from, and that's what the data says. There is a however, though, with an ellipses, so there's more coming on this. So what may be the case, though, is that longer standing Borrelia affects the body differently. There are some compelling studies, and Stephen Buhner in his wonderful book, Healing Lyme, 2nd edition, which is twice as fat as the 1st edition. So if you read the 1st edition years ago and didn't get enough, there's twice as much information in the 2nd edition. But basically, there are a number of compelling studies indicating that Borrelia is very good at changing its genetic expression over the course of time. So meaning that the Borrelia, even in different parts of the body, can look genetically different. So it's very confusing for the immune system. And over the course of time, they will express different genes to make themselves look different as well. So it's really this, as much as it's awful to be afflicted with it, you have to give props to the fact that they're very evolutionarily advanced. They're very, very good at what they do, and that can really lead to this intense or very effective, rather, immune system evasion. So maybe the reason that the ELISA is negative in all these cases where other testing says, oh no, it's actually positive, maybe it's because the ELISA is only able to pick up with that degree of efficacy just acute type Lyme, not the more chronic insidious stuff that we're all ultimately talking about. I think that talking about Lyme, of course there's acute Lyme and chronic Lyme, that's what people talk about, but actually talking about, thinking of it as almost an entirely different species or entity, if you will. It just behaves so differently, and I think maybe that's where the discrepancy is with the testing. So at the end of the day, as it says here, we know persistent Borreliosis exists, and basically over time antibodies may not be present. I spoke about this a fair bit at the vocal event. I recorded that on my own time afterwards, which is why I'm doing this now, so I don't have to do it later after my kids go to bed some night. And so that's on my YouTube channel, which the link is there. But just a couple of very quick slides here from that same talk. So, does persistent Lyme exist? And the answer is definitely yes. And this study ultimately indicates that, 215 patients, they all tested positive for Lyme with, ELISA test, Western blot testing, reassessed 3 years later, and around 53% of patients had chronic symptoms. So, that's proof right there that, yes, there's definitely chronic Lyme. There are a few other citations of other studies saying effectively the exact same thing. And there is this really great review article. So, a review article basically being a summary of lots and lots of articles on the same topic that basically has this wonderful summary basically saying the extensive evidence demonstrating the presence of post-treatment manifestations of Lyme should shift the debate from whether one believes in chronic Lyme to whom should be treated in what manner. In other words, stop squabbling about does this exist and say, yeah, it exists. It definitely does based on the studies. Just figure out what to do about it. So what are the limitations of antibody testing? So at the top here, so there's one study that ultimately indicated that about half of patients with the previous Lyme diagnosis, and they were, I think, all treated in the study, if I'm not mistaken, had a negative Western blot 1 year later. So from that, I would extrapolate that maybe that could the same type of information could relate to patients who have not been treated. They got sick, nobody treated them or identified Lyme for months and months or years and years or whatever it was, and then they're going and get tested and see, oh, I have all these symptoms of Lyme or co-infection, and I got tested with a Western blot and it came back negative. And maybe that's because they're not actually making those antibodies anymore. In other words, they're now seronegative. Similarly, this other study at the bottom showed that 60% of patients who had relapsed, like post-treatment, or even without treatment, were seronegative, and they ultimately had a worse prognosis. So in other words, they weren't making antibodies anymore. So there's not a lot of studies out there looking at this specifically, but these are a couple basically indicating that some patients in the later stages, in this case is only a year later for a lot of people suffering for 5, 10, 15 plus years kind of thing, no wonder that these tests are coming back negative all the time, because it appears that in a subset of them, in a significant subset, they just don't make the antibodies anymore. So that's one of the reasons that I effectively fell out of love with, say, antibody-based testing, like Western blot testing, pretty early on, because I just didn't really, if it came back negative, it's like, well, doesn't mean you don't have the Lyme, and you just dropped, $300 to $500 American, getting this testing done. So that's one of the reasons I've kind of fell out of love with testing. But fortunately, some good stuff came along a couple of years ago, which is what we'll talk about. Any questions about that so far, by the way? Okay. So with Western blot, so the sensitivity from that previous link that I had looking at the ELISA information, so the sensitivity is estimated to be between 50 and 75%, but if some patients are seronegative, as we just discussed, then that's pretty useless to us. And what does a positive test tell us? Ultimately, that the patient's been exposed at some point in the past. It doesn't necessarily mean that that microbe was even making them sick. They've done some interesting studies, not in Canada to my understanding, but in Europe, looking at endemic areas of Lyme, which we certainly live in one of those. And I believe they found, and I didn't have time to pull the study here, but basically I believe they found that about 22% of the people in that population were asymptomatic carriers. So meaning they tested a bunch of people at random in that population, people who, weren't sick, and they found that 22% of them tested positive for Lyme. So in other words, the bugs were in them, but not actually causing symptoms. So you look at, say, your really healthy neighbor, you think, man, I wish I was healthy enough to go mow the lawn like him or her, and maybe he or she has Lyme as well, but their immune system has been strong enough or robust enough to keep it under wraps. So just because you have a positive, if you're, as I like to say in quotes, lucky enough to be test positive with a Western blot for Lyme, it doesn't necessarily mean that Lyme is actually making you sick. And it also might be testing positive for a microbe that's been gone for a long time. So as I said earlier, if you've been treated and you've hit a plateau or didn't improve in the first place or what have you, and it was all based on a Western blot finding, maybe that bug was gone a long time ago. It's hard to say. Any questions about that? Playing for time again here. Does any of that sort of fly in the face of what you were previously, your previous conceptions about antibody-based testing or Western blots, or does that all seem pretty much in line with what you folks have heard historically? Oh, good. Okay. Sorry for wasting the last 15 minutes of your time. Just joking. Just joking.
Well, when it comes back, sometimes when it comes back positive, the doctors will tell you, oh, it's a false positive.
Yeah.
That's the next thing it comes back, no, it's a false positive.
Yeah, it's true. And actually this is a sample report from IGeneX, and a great example of that. So where this is actually an IgM Western blot coming back positive, both by the less stringent IGeneX criteria, more stringent CDC criteria. There are studies like review articles or whatnot saying if there's a positive IgM, because that's an acute phase marker in someone who's presenting with what they believe is chronic Lyme, they'll say, oh, well, the test is flawed because IgM is all gone within the first, I can't remember the numbers, like within the first 1 to 3 months or something like that. So they'll say, oh, it must just be a flawed test. It's like, or did the Lyme change its shape, so to speak? Did it change its genetic expression? And now the immune system's seeing it anew, making more IgM antibodies, and maybe the test is actually incredibly valid. But nobody's doing those studies or asking those questions, at least not in a policymaker sort of level. So basically with the Western blot, has anyone not seen a Western blot test before? Okay, great. Let's see if I can get my little laser pointer thing. Oh, look at that. So basically, These are all different protein bands of different sizes. For each band from the sample, there's either a minus sign or a plus sign, or sometimes multiple plus signs to say how, to what extent was the band positive. And basically, based on the CDC criteria, you have to have at least 2 bands that are positive from the following bands, so 23 to 25, 39, and 41. So for this patient, where the 39 and 41 were both positive, that's considered positive by the CDC criteria. IGeneX, they have less stringent criteria, so they basically have bands 83 to 93 kilodaltons, and 31 and 34 being potentially eligible bands too. So you need 2 out of those 6, I believe it is, to be positive. So that's what that is. So at this year's vocal event, Donna and I were chatting for a minute. Oh no, I said your name. So now you're going to be on YouTube. Yeah, I won't say your last name, so I'm sure there's several Donnas out there. So we were chatting at this year's vocal event, and one thing that Donna mentioned was that there seems to be some, if you will, like, for lack of a better word, sort of mysticism about like how do you access these tests and how are they done and that type of thing. So for each one, I'm going to talk about sort of the logistics of what kind of the test looks like and how you get it done and so on and so forth. So for Western blot testing through IGeneX, basically the lab can ship you a kit yourself, and then you can find someone to draw your blood. Some patients do that, or you can go to a clinic that provides the testing, like our clinic or other clinics out there, typically naturopathic clinics in Nova Scotia. Maybe some integrated medical clinics, but I don't know of any off the top of my head. And generally 1 to 2 tubes of blood are drawn. One of them needs to be spun in a centrifuge. So, if a nurse is listening, thinking like, oh, I can get one of my buddies to draw this or something on a lunch break, it's like you are going to need to, have them break into the lab to spin it down in a centrifuge. So that's the one little more complicated thing, I guess. But there are some services that will draw blood at your home, and I've heard that some of them will do this, and then they give you the blood back and send it off, and I don't really know how it all goes. We just do them out of our clinic, and the results come back within 3 to 4 weeks. The cost really ranges a lot depending on how much you're getting done, like the basic Lyme panel versus comprehensive, and then if you start adding in co-infections, it starts to add up. But I think the basic Lyme panel is about $300 US, give or take. There's shipping on top of that. Comprehensive is $500, and then co-infections are anywhere like $200 to $400 each per co-infection, give or take. But they do have packages and whatnot, so that's just a very rough estimate. So the next type of testing is T-cell based testing. So with T-cells are another type of immune system cell. So you may notice that the first few lines are exactly the same as the antibody one. So basically, microbe enters the body. These specialized cells present the microbe to the immune system saying, these bugs are not supposed to be here. What are you going to do about it? Various immune system cells are produced like antibodies, but we're not talking about those anymore. We're talking about another cell that's being produced called T cells. So T cells are called T cells because they mature in your thymus gland. Thymus starts with a T, so not too original on that one, but that's all good. Better than them being called, like, I don't know, Winkenhelmer cells after Dr. Winkenhelmer, who developed them. And basically, those T cells are created entirely independently from an antibody response. So this whole seronegative debacle, this whole, well, what if I don't make antibodies anymore after a certain number of time, or what if I never made antibodies in the first place? Well, that's not a problem when it comes to T cell based testing, because it has nothing to do with antibodies. Yes, T cells and antibodies absolutely interplay in the body, but their production is entirely independent. So those are T cells. So to my understanding, there are a couple of labs that do this test. It's called an ELIspot test, enzyme-linked immunospot assay. And Armin Labs is this lab from Germany that Donna has a brochure for there, and they sponsored the vocal event, which I think was very nice of them. And so they're one of the labs that are doing this testing. I don't know any details about the other labs that are doing the testing, so I can't speak to that. But basically, this is a graphic from a presentation that Dr. Schwarzbach, i.e. Dr. Armin Schwarzbach, who the lab is named it after his first name, which I think is unique and good and way easier to say than Schwarzbach Labs, I guess, for the international community, I suppose. So this is a graphic from one of his presentations. And so basically, I know the writing is small and it's not a fantastic slide in my opinion. He's a very nice guy, but this is not a fantastic slide in my opinion. But basically, what this is indicating, actually, I'll use my pointer for the YouTube crowd. So basically, there's the patient's blood sample, and from their blood sample, their lymphocytes, so specific types of white blood cells, are isolated. And then they are put in a little petri dish that has special types or a special type of antibody lining the bottom of it. They're antibodies that are only bred to detect the presence of certain cytokines, which are these cell signaling molecules that are made by T cells. And so there's a couple of different types that are made, but to my understanding, the most important one is this one called interferon gamma. So these antibodies are just waiting to see if any interferon gamma comes into contact with them, and if it does, then they will bind to it. So what ultimately happens is the patient's blood sample, their lymphocyte extract, along with some Borrelia antigen, so Borrelia body parts effectively, are put in that petri dish, and they're all mixed together. And so one of two things is going to happen. Either the patient has never been exposed to Borrelia before, or rather the patient's not currently dealing with Borrelia, and so their T cells are not primed to attack the Borrelia at all. So the T cells from their blood sample, which might be all primed to attack Streptococcus and Staphylococcus and viruses and whatever it is the T cells are attacking, they'll say, yeah, we've never seen Borrelia before, so they're not going to make any interferon gamma, so there will be no interferon gamma produced to ultimately bind to those antibodies, so the test is just going to come back negative. And we'll talk about how there's another slide that looks at this. But basically, the one scenario where they've never been exposed, they're not dealing with Borrelia rather, there's going to be no interferon gamma produced, so the test is going to come back totally negative. The other scenario is that the blood has been, or the lymphocytes have been extracted from a patient who's actually dealing with Borrelia at that time. And so those T cells are going to be just raring to go to react with Borrelia. So when those T cells mix with the Borrelia body parts and are put into that petri dish, they're going to make a lot of interferon gamma. That interferon gamma is going to bind to those antibodies, and the test is going to come up positive. So basically, it's kind of this roundabout way of figuring out, are the T cells in this patient's blood sample already primed to attack Borrelia? And if the answer is yes, then we know, oh, there must be Borrelia in their body. And what's also interesting, and I think very exciting and useful, is that it also gives us a sense of the degree to which the body is fighting off Borrelia. Because if there's only a little bit of activity, if there's only a little bit of interferon gamma, maybe that's in an infection that's actually on the way out. Whereas if there is a very robust response against that Borrelia, that would suggest, well, maybe this is a really active infection that the T cells are really fighting hard against. So it seems to give us this possibility of quantifying where the patient's at. The other thing that's quite exciting clinically is that T cells have a lifespan of approximately 6 to 8 weeks. So if you retest after 8 weeks, like, so the patient says, you've been treating me and I feel all better, or all my Lyme symptoms are gone, or what have you, you can wait 8 weeks and then test, and it should come back negative, which tells you, oh, the Borrelia is actually gone. Or if your test came back at a 50 initially, and then they say, oh, I'm feeling so much better, wait 8 weeks, retest, now they're down to a 3, it's like, well, that's still positive, but it's just barely positive. So it's like, okay, great, maybe let's treat you for 2 more weeks and then stop, because it looks like we've got pretty much all the Borrelia already. So there's kind of this quantification component to it. I'm going to go over the next slide, and then I'll ask if there's any questions, and we'll see how it goes. I really have done this before. Okay, so if there is interferon gamma produced, i.e. the patient actually has Borrelia, the red circle will be there, the second antibody binds, they expose it to an enzyme and another substrate, and it'll basically just start to glow essentially, so that when they take a picture of it with a special type of camera, then they'll see all these little black dots popping up. So this would be a very positive test, because it's showing that, geez, there was all of this interferon gamma being produced, and thus all these antibodies were being bound, and then it shows that exposure. In a patient who had no issue with, was not fighting off Borrelia, they'd make no interferon gamma, so none of that second enzyme and substrate and all that would bind. So you basically just see a blank petri dish. There'd just be one dot for the control well, and that's it. So that is the scoop. So any questions about the T cell based testing? Sure.
About the blood draw itself?
Sure. Yeah.
I found a woman that at a clinic that will take blood, but would the centrifuge that would be required, those clinics would not have that access to that, would they?
It's not a special centrifuge. It's not a magical one. So yeah, just 2,400 rotations per minute maybe, or per second. I don't remember. I don't draw blood anymore because I have residents, so I don't remember. But yeah, it's not a fancy centrifuge.
So they might have something there that...
Yeah, if they deal with like any standard blood draw, like if they're doing anything that requires basically if they're doing, unless they're only doing just very rudimentary, like we're only testing blood sugar, we're only running a CBC. Like if they do lipid profiles, like for cholesterol, they would have to have a centrifuge because you need that type of tube to run it. So
I was thinking more of that, like there's the blood clinics where you can go and get
Yep.
your blood drawn, and
Yeah,
it
yeah.
usually just goes to the hospital.
Yes.
But I don't know if those clinics themselves would have, so that you can just pay your $20, get your blood drawn, if they have the centrifuge right there, but it probably goes to the hospital.
Yeah, it's a great question. So the question just being about, like, can you just go to a blood collection site and then get it done there? My understanding is that there are certain policies about what they're allowed to do, and so I don't know that they'll effectively, like, they might not ship the blood off for you, and then they also might not just say, oh, we drew your blood and spun it and like, here you go, just to leave with it, so to speak. Like they have a certain level of responsibility to it, I believe, so they might not do that. But it always depends on who you know, so maybe somebody would do it. As long as they have a centrifuge, then you'd be all set. For the Armin Labs testing, I don't remember if they need a centrifuge or not. I think they don't, but you could just call the lab or call my front desk and say, hey, do you need a centrifuge for that? Because as I said, my residents do it and I just don't remember. But yeah, if for Western blot testing you need a centrifuge, for Armin Labs I don't think you do. So then it doesn't really matter. You could get anybody to draw your blood. But there is a but to that, but I'll get to that because you might want to do it through a clinic because it's markedly less expensive. But I'll get to that. Did that answer your question?
Yes.
Great. Yes.
I have a question from back a bit.
Sure.
What's your feeling on melatonin? Good or bad?
What is my feeling on melatonin? Good when that's what your body needs, and bad when you don't need it or you're really sensitive and it gives you nightmares and funky stuff.
Just to get to sleep.
Yeah.
Well,
And-
that's one of the many things that can take you to get to sleep.
Right. Yeah. It can be miraculous or do nothing, or some people really flare a lot. One of my mentors, this medical doctor from Germany / the States named Dietrich Klinghardt, he talks about using melatonin to help promote brain detoxification, essentially, because it is such a strong antioxidant. And well, I'm paraphrasing here. I never want to speak for Dr. Klinghardt, but the take-home message I've had is that if patients are feeling quite a bit worse from taking melatonin, you might want to be thinking about maybe there is a detoxification reason behind that. So that's kind of the scoop there.
You think if they're feeling worse, that the body may be detoxified? Is that what you meant? I kind of went into a brain.
No problem. Yeah, it might be an indication that there's too much brain detoxification happening, as evidenced by the fact that I've had a number of patients where we're trying to ramp up the dose of melatonin to a fairly high level, because in some studies for oncology patients that seems to be indicated. So like getting up to a markedly higher dose. And so virtually everybody that I've in my practice who have recommended that has been able to ramp up to that super high dose. I have patients with persistent infections that might start to feel worse with like a 5% of that dose kind of thing. So in other words,
When you say super high dose, like how many milligrams?
that's a great question. And just where
No specific answer?
there is a specific answer. I just can't talk about dosages because, I'm not treating you and and then not treating YouTube basically. So just for liability reasons, I can't talk about that specifics. But
Lately, the last few years,
Mhm.
sort of been pumping them out. Like it's hard to get them under 5 milligram tablets.
yeah, they're massive dosages now.
You have to take one at a time.
Right.
And build up to see how tired I'm going to get.
Right. Yes. Yeah. There are a variety of dosages now. It's which is useful because
Seems like they're pumping out the higher doses.
they're more common now. Yeah. But I mean, even like the health food store across the road, that clinic the Sante Center. I mean, that's okay. I can say that on YouTube. They have a health food store there, and like we were just in there the other day getting whatever it was that we were getting, and yeah, they had 1 and 3 and 5, I think, and maybe I don't think they had 10. Yeah, there are 10s out there now. Yeah, they're still available though in lower milligram dosages as well.
I'm gonna stick with the lower doses.
Right. Any other questions about? Any questions about T cells at all? I'm happy to talk about whatever, but okay, great.
I have a question.
Sure.
You're going to cover it.
Sure.
So I understand there's different labs, there are different levels of testing, and I would imagine that when one goes to a knowledgeable naturopathic doctor such as yourself, that you would help guide the patient into which lab to go, which test to seek first, or would you seek them all?
That is a great question. So if one sees a knowledgeable naturopath or even someone like me, then yeah, would we give guidance? And absolutely, yeah, definitely. And I'll talk, and then or would we recommend them all? And so I will touch on that as we go along. But yeah, all right. So with Armin Labs, to my understanding, there's been one, in my opinion, good independent study looking at the sensitivity and specificity of Borrelia ELIspot testing. So it indicated an 84% sensitivity, which is pretty darn good, and a 95% specificity, which is hard to ask for much better than that. There's the reference for that if anyone wants to look at that. And there are a couple of other studies, which I'll mention another one in an upcoming slide. And yeah, basically, as I mentioned, it seems that it could reflect the degree of T cell activation could reflect the degree to which the immune system's dealing with the infection. So it could actually maybe give us a sense of where is the person at in their course of dealing with that particular infection. If the level's really high, it's probably pretty active. If it's low, maybe it's not as big of a player as one thought. If it's negative, then maybe they don't have it. So if you had a positive Western blot coming up, like say an IgG Western blot was positive, and you thought, oh, I'm dealing with chronic Lyme, but then you did an ELIspot test through, say, Armin Labs or equivalent for Borrelia, and it showed a really low level of activity or absent activity, it would suggest, well, maybe that is just that I was dealing with Lyme before, and now I'm not. Maybe I did successfully treat it, or my body fought it off, but I picked up Lyme and Bartonella and Babesia and Antiplasma all in the one fell swoop, and my body dealt with the Borrelia, and it's maybe still dealing with the other co-infections, but not the Borrelia specifically. So could be useful to, that could be one potential use of this type of testing. So this is an Armin Labs test result, and from one of my patients, obviously, with all of the identifying data removed. And so basically, this is page 1. So with the Borrelia ELIspot, they look for 3 different parameters. They look at the full antigen, so basically all the body parts of dead Borrelia. They look at this outer surface protein mix, which are sort of surface protein markers of Borrelia, and then this other one called the LFA1, which is lymphocyte function antigen, which evidently has some utility in terms of figuring out if a person is maybe having some kind of an autoimmune type response to that Borrelia. So if they have an autoimmune condition and Borrelia, it could give insight into whether that autoimmune condition is actually being caused by or contributed by that Borrelia. So the reference range, as you can see, well, maybe you can't see, it's not the best, a little bit hard to see, I guess, but so the unit they use is the SI, which is sensitivity index, and to my understanding, that's effectively how many little black dots come up on the picture, essentially after they've done the test. So if there's between 0 and 1, that's negative. If it's 2 or 3, that's a weak positive, and then if it's anything more than 3, that's considered just a positive across the board, but the higher the number would suggest, to my understanding, a more sort of robust immune system response against that particular antigen. So for this patient, you can see, 3, 4, and 2. So, he does have a positive here, and then a weak positive. So not super compelling. This patient was interesting because we actually ran the DNA testing, which we're going to talk about in the next section, the last test too, so I'll be out of your hair relatively soon. And he was negative across the board and presenting with some pretty significant symptoms that I was very surprised that nothing came up with that testing, was that tests for, as we'll discuss, Borrelia, Bartonella, Babesia, Ehrlichia, and Anaplasma. And I thought, man, like, how does this guy test negative for all of these? So then we ran this test and we saw, well, that's a pretty darn weak Borrelia ELIspot result. So maybe that's why. Maybe it was just a sort of microbe in the background and it wasn't enough to actually come up on the other test. And so when I looked at page 2 of his results, which is actually cut off here, so we tested for Mycoplasma, and I believe that was a 1. So that was negative, or it was a weak positive or something like that. I think it was negative. I think it was a 1. But then we also tested for a couple of viruses, and we saw a cytomegalovirus ELIspot was at a 43, which is really, really high. So it used to be a 4 or more. He was at a 43. And then also we tested for HHV6, human herpes virus 6, nothing to do with oral or genital herpes, totally different virus. They don't do ELIspot testing for that virus yet, to my understanding. So we did a Western blot effectively, and that was positive too. So it was really good that we did this additional testing because it showed, oh, we're actually dealing with a pretty major viral issue. It's not evidently related to Lyme or those common co-infections. So that's what an Armin Labs test result looks like. Any questions about that at all, Donna?
You said viral issue. Could it be like Powassan virus? Because we do have that here now.
I don't think they test for that. So maybe, yeah, that might be part of the milieu, if you will, of viruses. Yeah, there's other viruses they test for as well, like Epstein-Barr virus, and I think they test for Coxsackie B virus, which is another one that's sometimes implicated. But yeah, they don't have that one in the mix. But it's a great question.
We've had a few cases in the province.
Maybe. I don't know, but yeah, they don't test for it. Anyways, that's a good question though. Any other questions? All right. So limitations of this testing, I think it's a good test. I like it. I've been recommending it to patients, but I think it's important to be aware of the limitations of the tests. So as of June 2018, so as of right now, to my understanding, there are no studies looking at ELIspot sensitivity and specificity for any co-infections. So there's that study showing it for Borrelia, which is great. And then we hope that it's good for the co-infections we're running it for, but we don't know. We can make the assumption that the specificity, so if the test result comes back positive, we should be able to be very confident. It should have a high specificity, because otherwise, like, where the heck would those T cells be coming from? But it's a question mark for me. What's the sensitivity? So in other words, for this patient, where say his Mycoplasma came back, showing there's no issue. Well, does it only have a 40% sensitivity, meaning there was only a 40% chance it would have picked up? So if we get negative results, I don't know to what extent we can definitively hang our hats on that. If a Borrelia comes back negative, I know there's an 84% chance that information is actually accurate. But for the co-infections, it's just all a big guessing game because they haven't done the studies. Now, we contacted the lab to see if there's anything on the pipeline, because I was doing this presentation. I thought, it'd be nice to know. And evidently there are some studies that are just about to come out, so we'll see what comes up. But right now, they've only looked at Borrelia specifically. Although we can obviously test for all these other microbes and just, once again, assume that, well, if it comes back positive, we can be likely quite confident in that. If it comes back negative, it is a bit of a question mark of, is it actually negative? Which is why sometimes when we don't find anything with a certain type of test, we may want to look at running another type of test. So to touch on your earlier question, do I recommend patients run every test, to see what's going on? It's like, absolutely not, because nobody comes in with 2 big bags of money and says, please help me spend this. It's always, I have no money and please help me get better. That's almost always the case, which is fine. But it's usually, well, let's run a test and then see what happens. And if it comes back negative, then, well, what do we do from there? But sometimes it's, well, maybe we run another test or we do something else. But that's kind of doing it one step at a time. The other limitation of note is that the test may not be that great in diagnosing patients with neuroborreliosis, i.e. neurological Lyme. There was a study, it was a small study, but it indicated that it only had a 36% sensitivity and an 82% specificity, and there's the reference for that. So those numbers aren't fantastic. So I unfortunately didn't have enough time to send that to Armin Labs to say, hey, what's up with that? Because what is your rebuttal, and do you think that's true and valid or whatnot? And so I don't know, but that is a study that's out there. So maybe for neuroborreliosis, if I thought, I think you're really probably suffering from neuroborreliosis, maybe we wouldn't want to run that one first. Maybe we'd want to run a different one and see what was going on. So the lab is located in Germany, although amazingly their turnaround time is only 3 to 5 business days. So how does that work? So they're in Germany and they're busy and very popular, and 3 to 5 business days, and then say IGeneX in California, it's like 3 to 4 weeks, and I know everybody's busy and it's all good. Maybe I don't know. I used to run Western blots a lot when I worked in a cell biology lab, and by golly, it doesn't take all that long to run a Western blot. But maybe there's really busy. I don't know. In any event, we ran a test, one of these panels on a patient last Tuesday, and I just got the results sent to me today. So they're that fast. So very, very fast. It is a blood draw. My recollection is it's somewhere between 2 to 4 tubes of blood, depending on the number of microbes that are tested for. And the kits can be sent directly to patients, so you don't have to do it through a clinic as long as you can find someone to poke you and steal your blood for this testing. Although my understanding of it is that if you are tested through a clinic, then you get a discount of about 25%. So in other words, the requisition forms that are mailed directly to patients have a certain price. The requisition forms that are sent to kits that are sent to clinics, they're about, I think it's actually 27% less if I'm not mistaken. And so if you do it through a clinic, like we have one patient, for example, who lives a ways away, and so we mailed a kit to her, and then she found somebody local to draw her blood, and it was all good in that they got the results, and she saved a bucket of money because the testing is relatively expensive. So that's where I mentioned that doing it through a clinic, like even if we don't actually do the blood draw, then kind of mediating it through a clinic like ours or another one could be more cost effective. And actually we had a patient who also was from a ways away who had a kit, and she brought it to us, and we said, hey, we'll use your kit to draw her blood, and we said, we'll use your kit on another patient with just a different requisition form because we're going to save you like $200 or something like that, because she wanted a really comprehensive panel done. In terms of the cost of the Armin Labs testing, with this 25% discount, it works out to be, all the pricing is in euros, and with the exchange rate such as it is right now, the ballpark figure is that it's about $100 Canadian just for the shipping cost. It's $100 for each. If we're doing, this is ELIspot testing, the Tcell based testing we've been talking about. They do other testing as well. They do antibody based testing and some other things as well. But for the Tcell based testing, it's $100 per co-infection to have tested. And then if you're getting Lyme Borrelia tested, it's $200 Canadian, give or take. So if you were doing, say, Lyme and Bartonella, it's $100 for shipping, $200 for the Borrelia, $100 for Bartonella, so $400. If you tack on Mycoplasma, it's another $100. You just basically do the math. So that's the rough cost of it. So decent chunk of change, but ultimately less expensive than some other independent lab testing places out there. I think this is the last Armin Labs slide. So any questions about the Tcell based testing or anything so far? Okay. All right. This one's really fast, and we'll be done. So DNA based testing. So basically, microbial DNA can be identified via this type of test called the polymerase chain reaction test. And basically, that's a test where if they have even a teeny tiny amount of DNA, they can run it through this amplification process and basically make a ton of DNA so that it can then be picked up using a lab test. So I ran not many of these when I worked in a cell biology lab, but it's not that, it sounds cool, but it's really just, add different reagents to different test tubes and incubate, and there's not a whole lot of magic to it. But if there is DNA in that sample, then it will test positive in the lab. So it's totally different type of test in that it's totally independent of any type of immune system response whatsoever. So if a patient has Borrelia and you run a Western blot, well, they have to make antibodies for you to be able to detect. If you're running an Arman Labs test, they have to make T-cells in order to detect those through the testing mechanism. With DNA-based testing, the bugs just have to be in there, and then they have to be in the blood sample or whatever sample it is you remove from the body, and then they run the test and they find the DNA or they don't. So it's a great test. It's really a gold standard test in any type of microbiology testing, so it has a very high specificity, but the big problem with PCR testing up to this point has been that it's been very insensitive. I did not have a chance to hunt down studies for you, but what has always been mentioned to me, whether it's through iLads or at other conferences or whatnot, it has around a 15 to 30% sensitivity in the blood, so it's really low. So if you get quote unquote lucky enough to have a positive PCR, then you can say, wow, I'm definitely dealing with these microbes in my body right now, but it doesn't come up all that often. I've seen very, very few positive PCR tests in my practice, and I've seen lots and lots and lots of IGeneX results, so where we're of course doing it through blood testing. There is another lab, though, that came out, the lab was around for a long time, but about 2 years ago, they started offering this test through this lab called DNA Connexions. They're based out of Colorado, and they use a method of provocation testing, which seems to dramatically enhance sensitivity. So the PCR testing is great for specificity, really low sensitivity. Using this new method, it seems to be quite a bit more sensitive, which was quite exciting. So I'll explain what's involved with the protocol for how one does this provocation, and it should all make sense. So effectively, one voids one's bladder, then one needs to exercise vigorously for about 20 to 30 minutes, which people in the room or people listening might think, geez Louise, if I exercise vigorously, I probably won't be around 20 or 30 minutes later. So it's within, your personal comfort level, essentially. And this actually, like, all joking aside, it can be a deciding factor. I've had a few patients where we were all set to do this test, and then they said, oh, exercise vigorously. Like, no, this isn't going to happen. Like, I will be flared up for a month if I do that. I'm not going to do that. And so then a blood draw based test, like say an Armin Labs test, has been a much more attractive option. So that is a sticking point for some patients. One of said patients did this testing anyways, did not do the vigorous exercise, and everything came back negative across the board. Then we wound up doing the Armin Labs test, and then we saw several microbes come up. So it does seem like the exercise is really, really important. There's this optional component where one can have deep tissue massage done to their arms and legs and other body parts if so inclined. And the whole idea with the exercise and the deep tissue massage is to try to mobilize the microbes. The big problem with these bugs, of course, is that they like to hide out in our tissues. They don't moonlight in the blood because they're too smart for that. Say Bartonella will hide, say, inside of a red blood cell, or it will hide in the blood vessel lining, but it's not going to just hang out in the serum where it's just going to be an easy target for antibodies or T-cells or whatnot. They're going to hide out in these hiding places. So the way I think of it is that we're trying to jostle the tissues to get the bugs out into the open. You might be thinking, isn't that going to provoke a herx in some people? Do you really want all these bugs coming out in the open? And in our experience, where we've done this test with quite a few patients to date, it's been the exception to the rule that anybody's flared, but we have seen some pretty juicy herxes from doing this. So like those patients who didn't want to do the exercise or whatnot because they knew their bodies well enough that they would flare like crazy if they did, once again, something like Arman Labs might be a better option in those particular cases. So that's kind of in my opinion, the brilliance behind the DNA Connexions approach, because they're saying, well, geez, the PCR testing is great, but we know the blood testing's it's fallible. So maybe by getting bugs chased out into the open, it'll work better. And lo and behold, it does. One limitation of the DNA Connexions testing, in my opinion, is that, to my understanding, they don't have any studies looking at the exact data on their test results, or their testing method, I should say. So where there's that one Armin Labs test showing us the sensitivity and specificity of the Borrelia ELIspot test, there is no such test, or no such study rather, for DNA Connexions method, to my understanding. I've not been able to find one, and so I don't believe that one has been done. However, what they do have is all of their lab data. So they'll say, well, we've run whatever, like tens of thousands of tests or hundreds of thousands of tests or whatnot in the last couple of years. They're a pretty darn popular lab, so lots of tests. And so my understanding is that about 84% of their tests come back positive with something. Now, it's a skewed sample being sent for the most part, because you're not going to drop the cost of this test, which I'll get to on an upcoming slide, just willy-nilly. So you're not going to run this test on someone you don't think has Lyme or a co-infection. So it is a skewed population, although they do receive samples from patients who say, I was sick for years. I want to see if I still have these bugs in my body. So we do have that data from like the lab's data, but that's all that there is. So it hasn't been sort of independently verified, so to speak. What we have seen in practice is that in patients where we thought, it really sounds like a Babesia presentation, it really sounds like Bartonella, it really sounds like Borrelia, what have you, it's been quite reliable coming back with the bugs that we thought it was going to be. So for what that's worth, and I've heard other colleagues say the same thing as well. So it does seem to play out quite usefully in practice, but they just haven't done the independent studies to verify things, as I mentioned. I mentioned one of my mentors, Dr. Klinghardt, on an earlier slide, and so he has sort of propagated a more comprehensive provocation method, which basically involves applying either an ultrasound or an infrared laser to different body parts where the microbes like to hide out. So I've listed those there. So when we do this testing in our office, we recommend that patients come in to, they do the exercise, they do deep tissue massage, like we do it all, my residents do it all in-house, and then we also apply these different devices to different body parts to say, hey, if you're going to drop, well, the cost of the test, it's $500 US. So if you're going to drop that kind of money, we want to make sure we give it the best kick of the can we can. So we do these extra bells and whistles to try to flush things out into the open that much more effectively. Any questions about that so far? I've got a couple more slides on these guys, but okay. So one question would be, why test urine? I keep mentioning Stephen Buhner and DJ Klinghardt. I guess you can tell who my heroes are. There are other people I study with too, believe it or not, but these guys just made this this presentation, I guess, exclusively. So in Stephen Buhner's second edition of Healing Lyme, he talks about the sort of the physiology of, or the pathophysiology, I suppose, of Borrelia at least, where once the Borrelia has got into the body, one of the first places it goes to is to the bladder. And evolutionarily speaking, that makes sense. As it says here, bugs are smart, because if I'm Borrelia, I know that I want to keep this cycle going. So, tick back to human, or tick to mouse to human, or deer, or, the whole shebang. And so what are you going to want to do if you're Borrelia? You're going to want that host to urinate you out onto the grass where the ticks and the mice and all that stuff are hanging out. Now, we generally don't urinate in the grass in our modern day society, but maybe some of us do. But that's ultimately where they like to go. So these microbes do have a high affinity for the bladder, and so that's why testing urine makes a lot of sense.
I do have one question.
Sure.
Instead of using ultrasound or infrared, if you did acupuncture, would it stir up those areas and those bugs moving?
That's a good question. Yeah. So would doing acupuncture help to get things moving more? I don't know. Maybe. Where I do acupuncture as well, or used to do a lot of it and less so now, but it's a fantastic therapy and I love it. And kind of to get acupuncture is very good at getting things moving in the body, but my understanding of it from more of a Western physiological point of view, like you can talk about qi and all that great stuff, and it's wonderful, but when you translate that into Western medical terms, so to speak, it seems to be, in my experience, in my opinion, mostly working through stimulating the nervous system to get things going, which I think is why you can stick a needle in somebody's foot and, stop their headache or whatever it happens to be. It seems to be very nervous system mediated. I think that it's pretty subtle. So I don't know, I think of these as actually really jostling the tissues to mechanically get them chased out into the open. So I think the acupuncture could probably help, but I don't know. We haven't tried it, but it's a good idea.
Thanks.
Yeah, it's a great thought though. Other questions? All right. So I mentioned already, I think that the DNA Connections lab is based in Colorado. Kits can be shipped directly to patients, and you don't need to get involved with a clinic in any way, shape, or form if one is so inclined. They have all the instructions in there and all of that. They, talk about when to void your bladder and exercise and that type of thing to consider deep tissue massage. They won't talk about ultrasounds or red laser or infrared lasers or anything like that. And there's no cost difference whether you get the kit shipped to you or to the clinic, unlike Armin Labs. And as it says here, the urine test using the traditional protocol, like without the ultrasound and whatnot, can easily be done at home. No blood draws or centrifuges or anything of that required. Results typically take 3 to 4 weeks in our experience. The lab has gone through phases where sometimes it's been 2 weeks, sometimes it's been 5 weeks or more, but lately they've been pretty darn good getting it back within the 3 to 4 week range. And they do have a rush option available, which is I think like $150 US. So you really want that rush, I guess. That's what it's going to cost you. So this is a sample report, and I'm sorry the writing is so small, but basically they test for Borrelia burgdorferi, they test for Borrelia burgdorferi outer surface protein A, B, and C, so they test for those specific antigens as well. They test for 3 different species of Babesia, 3 different species of Bartonella, 2 other species of Borrelia, including Miyamotoi, as was mentioned, and then recurrentis as well, and then a species each of Ehrlichia and Anaplasma, so kind of thinking of it as a 5-in-1 test. For the most part, we've seen kind of your typical, Borrelia burgdorferi, Babesia microti, and Bartonella henselae come up. I don't think we've ever seen an Ehrlichia or an Anaplasma come up to date, but every once in a while we have a more obscure species of Borrelia or Bartonella or Babesia come up. So evidently the lab is going to be expanding this profile to include more species and possibly other microbes entirely, such as Mycoplasma, which would make me really happy because that's something that comes up semi-regularly. But that's what a profile looks like, and basically, as you might be able to see, so if there's a little check mark and it's actually highlighted as well, then those are the microbes that come up, or if none of them come up, then the none at the bottom is highlighted. Any questions about that before I change the slide? Okay. So in summary, I think there are significant benefits to testing for Borrelia and other microbes. Each test has its strengths and limitations, and comprehensive testing is probably the best option. However, cost limitations will sort of lead to that being something to think about. It really kind of depends. It is a little bit less expensive to do the Armin Labs testing out of the gate. So, I give patients the option, and where I think with the DNA Connections, where it seems to have quite a good sensitivity overall, and it actually tells us is the microbe in the person's body or not. It's not telling us like an antibody test, like were you exposed at some point. It's actually telling us is the bug in the patient's body right now. I think that one and the Armin Labs testing, those are the ones I recommend. But sometimes cost-wise, we'll kind of start with Armin Labs and then complement that with DNA Connections if we need to. But it just kind of depends on pocketbook and all of that good stuff, and also turnaround time too. Like the Armin Labs, getting results in less than a week, it's pretty attractive. So that is it. So if you folks have any other questions, if you have questions about the presentation, then I'll answer those, and then if there's questions about other stuff, I'm happy to answer those too. I'll just stop this recording so that we don't drag it on for the folks on YouTube. Donna?
The DNA Connections, I must have missed it because I was glancing down and reading about the urine tests. Cost-wise, you said, when you saw the check marks, what would that test have cost?
Yeah, so what's the cost of DNA Connections for that panel that I showed? So with DNA Connections, in terms of Lyme and co-infections, they only have one panel, and you just saw it. So it's a all or nothing test. So that everything you saw there, it's $500 US. So
that's probably cheaper than if you wanted a whole bunch of things checked on or IGeneX.
Yeah, both Armin and DNA Connections, to my understanding, are quite a bit less expensive than a comprehensive IGeneX panel, and when you're comparing it head to head, although that being said, Ehrlichia and Anaplasma are tested because they're very, they used to be classified as the same genus, which, when Ehrlichia and Anaplasma are the genus names, the species are the second name after that. So they used to be classified as the same thing. So in other words, they're very closely related. So with Armin Labs, they do an ELIspot that combines them both essentially. So if you were to do an Armin Labs panel for everything DNA Connexions tests for, you'd have $100 for shipping, $200 for the Borrelia ELIspot, and then another 100 for Ehrlichia, Anaplasma, Bartonella, and Babesia. So you'd be looking at about $600 Canadian, give or take, all in. Whereas this panel through DNA Connexions would be $500 US. So with the exchange rate, it just really depends on where the exchange rate is. So pretty close, maybe slightly cheaper for Armin Labs actually, but pretty darn close. And then if you do the sort of the fancier testing through our clinic, then you're on site for about an hour. We charge half an hour for that time, so that's another $85 at our clinic at least. Whereas if you're doing the Armin Labs, if you're an existing patient, we don't charge anything for the blood draw. And anyways, so it does kind of work out to be a bit cheaper, but it just depends on sort of what we're suspecting. What we've been doing a fair bit of in my practice is doing testing for Borrelia, Bartonella, Babesia, and Mycoplasma, because I find a fair bit of Mycoplasma. And so that panel, I think, I'm not going to count in front of you guys again, but basically it's like, I think $500 or maybe $600. And I think it's 500. And so we've been doing that a fair bit because, as I said, the Ehrlichia Anaplasma just doesn't come up that often for us. But it's always good to kind of just test for everything, but usually don't have that luxury. So did that answer your question?
Yeah.
Okay, great. Any other questions about the presentation overall? Okay, I'm going to shut this off.